Dear ladies and gentlemen, welcome to Swingotech's first webinar of 2025. We have a history of interesting webinars we do all over the year, and we want to start the year off with a very interesting one. My name is Florian Uhle. I'm serving as a Chief Medical Officer of Swingotech, and I'm delighted to be your host of today. We as Swingotech committed to provide innovative diagnostic solutions for physicians treating critical ill patients. And the goal is to enable those physicians to make personalized treatment decisions for finally better outcomes for these complex patients. Let me allow to mention two housekeeping points before we go into the topic. First of all, the webinar will be recorded today. So when you have colleagues who didn't make it today, please inform them, and we will have it on the website very soon. So everyone can have an on-demand view of this webinar. And secondly, for today, for all the live participants, we have some reserved time for question and answers after our presentation. So please put your questions in the chat if you have any. Our webinar today deals with one of the hot topics in intensive care: how to deliver best possible renal replacement therapy for complex patients, and specifically today to patients after cardiac surgery. Especially when it comes to when to start dialysis and when to stop dialysis, evidence is shaky, and sometimes there's no evidence at all. And to cover this topic, I'm very delighted to introduce our speaker of today, and this is Professor Dr. Bernardi from the beautiful city of Vienna. Professor Bernardi is a cardiac anesthetist and intensivist and serves as deputy head of the Division for Cardiothoracic Vascular Anesthesia and Intensive Care Medicine within the Department of Anesthesia, Intensive Care Medicine and Pain Therapy. He has a very strong clinical and research interest around acute kidney injury, renal replacement, as well as absorption therapies, and has recently published the results of an observational study about how proankyphyllin, one of the assets and solutions Swingotech provides, could be of value during complex decision-making in such patients. Without further ado, I'm looking forward to an interesting talk and want to hand over to Professor Bernardi. The stage is yours.
So thank you for this kind introduction. I hope you all can see the presentation now. And within the next 15 minutes, I will tell you some practice-oriented management of acute dialysis after cardiac surgery, some strategies and challenges, and in the clinical practice. So this is my conflict of interest and now I will tell you something about acute kidney injury. Well, acute kidney injury is a common and serious complication. It occurs in up to 18% of all hospitalized patients, with about 30% incidence after surgical procedures, with the highest incidence after cardiac surgical procedures with up to 42%. Why is this so? Well, just think about a multifactorial disease. You have the cardiopulmonary bypass, which leads to hemolysis and the production of free radicals. On the other side, you have an ischemia and reperfusion injury leading to cell death. And also you have low flow, low pressure conditions with hypothermia and bleeding complications, also leading to a reduced renal perfusion with the end of a cardiac surgical associated acute kidney injury. How to diagnose acute kidney injury? Well, this is more or less a repetition. Since 2012, we have the KDIGO staging guidelines, which stages acute kidney injury in 3 stages, depending on the severity, and it's more or less an increase in serum creatinine over time and/or a decrease in urinary output over time. Does acute kidney injury affect the outcome of our patients? Yes. We know it's well documented, and we know very well that even minimal increases in serum creatinine after cardiac surgery already start to increase mortality. This is known since more than 20 years now. Also, with increasing stages of acute kidney injury, you have an increase in your risk of mortality on the long term, and also on the short term. You can see even after 30 days, there increases in the stages of acute kidney injury affecting your survival. How is it in those patients who are most severely affected with acute kidney injury, those needing an acute renal replacement therapy after cardiac surgical procedures? We compared those patients with patients who already were on preoperative dialysis with chronic kidney disease, and you can see here that when your patient needs an acute renal replacement therapy, you have an increase of at least 15 to 20% in mortality compared to those who already were on renal replacement therapy before the surgical intervention. Why is this so? Well, let's say the kidney is influencing nearly every organ system in our body. Just think about the brain with uremic encephalopathy. We know the well-documented increased mortality in chronic heart failure patients when you have an acute kidney injury. The lung is influenced by fluid overload, pulmonary edema, and also pneumonia in the end. And also the interactions with the liver and the immune system are well documented. So when we talk about diagnosis of AKI, as I told you before, we also have to talk about the limitations of acute kidney injury diagnostic, which is more or less the gold standard biomarker of serum creatinine. And we all know that serum creatinine has some limitations depending on the sex of the patients, depending on the body composition, the nutritional status of the patient, and also the hydrational status of your patient. And when we look at urinary output, then it's quite difficult to give you a good answer if it is a good marker even after surgical procedures, because we have in surgical patients preoperative fasted patients with a relative hypovolemic state. We have narcotics for the operation, which leads to vasodilation. We need some PEEP for the mechanical ventilation during the surgery. And we also have, depending on the surgical skill, a certain amount of intraoperative fluid and blood loss. This leads to a hormonal regulation of a decrease in atrial natriuretic peptide and an increase in antidiuretic hormone. And in the end, the body increases water and salt retention to increase the circulatory volume, and this goes hand in hand with a decrease in urinary output, meaning that the perioperative urinary output does not facilitate an early detection of acute kidney injury after surgical procedures, I would say within the first 6 to 12 hours. These are reasons why science focused on renal biomarkers also more than 20 years ago. And in this plot from 2010, you can see how many biomarkers have been identified so far. And in this very busy plot, you do not have to read it. Marlies Osterman tried to sort those biomarkers and to classify them to stress markers, damage markers, and functional markers to help. And biomarkers are needed to help in risk assessment, prediction, and diagnosis to grade the severity, and maybe they also can help us in telling us the recovery of the kidney function. The use of biomarkers led to the introduction of care bundles in those patients who were identified using biomarkers at high risk. And when care bundles were introduced to those who are at high risk, several studies found that using of care bundles at high-risk patients is reducing the incidence of moderate to severe acute kidney injury after surgical procedures. This is not only in cardiac surgical procedures, but also in major surgical procedures shown. What we also learned from biomarkers is that damage occurs in nearly every patient when we look at cardiac surgical procedures. So we looked at neprilysin 5 years ago. This is a damage marker in the tubular brush border. So when the tubular brush border is getting damaged, then neprilysin is flushed out with the urine. And when you find neprilysin in your urine, then you know you have a severe damage to your tubular brush border. And what we found is not only that we can distinguish already at the end of surgery between patients who are getting an acute kidney injury afterwards. But what we also found is that every patient had an increase in neprilysin, meaning that every patient had some certain amount of kidney damage, not saying us if it is clinically relevant at that point. This leads me to the core topic of this talk, to talk about timing and strategies for those who are severely affected with acute kidney injury and needing a renal replacement therapy. Well, when we ask the question, when do we have to start continuous renal replacement therapy? I can answer you. There are several studies out, multi-center studies who have answered this. When you have an absolute indication, just think about on severe hyperkalemia or metabolic acidosis, then start renal replacement therapy immediately. But when you have an relative indication, you can wait and see. It is known from several multi-center studies that a delayed strategy is not affecting the mortality and it's not affecting the kidney recovery. That leads me to the next part of this talk, talking about recovery. This is more or less the black box when you talk about continuous renal replacement therapy. So when can we stop our CRRT therapy? Well, it is recommended to stop renal replacement therapy when the kidney function has recovered. But when we look at native kidney function, it only can be assessed during the interdialytic period, which is during a continuous renal replacement therapy, I would say, difficult. What we know is that urinary output is the most significant predictor of successful CRR discontinuation. But this result is negatively affected by the use of diuretics. I think nearly everybody is using diuretics during a CRR discontinuation. And when you do not have urinary output at the time of discontinuation, then this is a worthless marker. And you have clinical situations where the urinary output is not there at all, but maybe the kidney function has recovered. Just think on right heart failure and negative balances for several days. So what we know is that we have a lack of information on renal recovery under CRRT. We have a wide variety of different approaches, institutional variations, individual variation, even on the same ICU, you have individual variations in when to stop CRRT. We have a lack of standardized screening protocols. The only thing we know is that there are independent predictors for restarting renal replacement therapy, and they are more or less depending on the length of duration of the renal replacement therapy and the severity of the sickness of your patients. This led to several biomarkers to be analyzed if they help clinicians in saying if a recovery of the renal function is there. But those studies are heterogeneous, not only in the used biomarkers, but also in the time point when they were measured. And also there are a lot of urinary biomarkers. So in the end, when there is no urinary output, those biomarkers cannot help you very much. But recently, a novel biomarker came up, which maybe can help us. And now I will show you some information on proenkephalin. Proenkephalin is an enkephalin peptide cleaved from the same precursor as mature enkephalins. Just think about metenkephalin or leukenkephalin. Enkephalins stimulate the kidney function. This is known, and it also is known that proenkephalin reflects kidney function very well, and this pathway is not affected by continuous renal replacement therapy. We know that proenkephalin shows a good correlation in patients with critical ill sepsis, and it is also has also been published recently that proenkephalin assesses the estimated GFR as good as creatinine-based estimated GFR rates. What we did is we performed a study on elective cardiac surgical patients. We performed an observational trial, and we wanted to know in elective cardiac surgical adult patients who needed postoperative renal replacement therapy if proenkephalin can help us predict a successful liberation from continuous renal replacement therapy. And therefore, we measured proencaphalin after the diagnosis of acute kidney injury, and we also measured proencaphalin when the clinical decision to discontinue renal replacement therapy was done. And then we looked if there is a difference in the proencaphalin levels of those patients who had a successful liberation compared to those who had unsuccessful liberation. What we found is that we can distinguish very well between patients who had a successful liberation in continuous renal replacement therapy compared to those with unsuccessful liberation. And we also found an optimal threshold of 126 and below for proencaphalin to predict a successful liberation with an area under the curve of 0.8. Well, I showed you the results of our study, which are those two plots here. But when we look closer in our study results and on results we have not published yet, is that we found maybe a sign also at the time point when CRRT was started. So it were only 20 patients. So with an increase of the patient number, maybe this sign is a bit stronger. But we also found maybe already a difference at the diagnosis of AKI when no CRT has been started at all. And now I will show you a practical approach, how we are doing it in Vienna when we use CRRT in our patients. When you have an absolute indication for continuous renal replacement therapy, then there is no discussion. We start with continuous renal replacement therapy. When we have a relative indication, then we perform a wait-and-see tactic. So we reassess the indication, and when an indication is given, we start the CRRT. When we have our hemodynamic, respiratory, and metabolic targets reached, and we have urinary output and/or the end of filter lifespan has been reached, then we stop CRRT, and if this is not the case, then we continue CRRT and reassess daily our targets. And when we have stopped our CRRT, we still continue reassessing our hemodynamic, respiratory, and metabolic stability. And if there is something failing, then we restart renal replacement therapy, and we also consider to switch to intermittent hemodialysis. So when you ask me where points and recovery marker can be introduced, then I can say in those patients where the urinary output is low or absent, maybe a renal recovery marker can help us in the decision to stop CRRT. Also, in the daily reassessment of CRRT, we can have the help of a biomarker helping us to stop CRRT earlier. And maybe we can also say in the relative indication if an CRRT is necessary at all, but this needs to be confirmed in larger studies. So let me conclude to you. Patients and CRRT management remains challenging after cardiac surgical associated acute kidney injury. An earlier identification of patients with recovered kidney function is needed, not only to reduce unnecessary prolonged CRRT durations, but also to improve patient outcome. Just think about early mobilization, and it also helps us to conserve ICU resources and reduce costs. Proencaphalin seems to be a promising biomarker capable of predicting successful liberation from CRRT, but this needs to be validated in a larger number of patients. And what is also needed is a comprehensive physiological understanding of the acute to chronic kidney disease transition. So thank you very much.
Yeah, thank you very much for this intriguing presentation. Perfect in time, and especially you're sharing the insights, how you do it, how your algorithm and workup works clinically. Was very interesting to see, and I think on such slide it becomes obvious why this topic is not a very easy one, which patients can be stopped and which do further require renal replacement therapy. There are a lot of factors driving
such patients into renal replacement therapy, and yeah, it's a complex decision making. We have some questions. I would just start, and if there are others coming up, please feel free again to put it into the webinar chat. Maybe a question making this topic a bit bigger, outside the cardiac surgery field. What do you see as similarities and differences when it comes to such decisions in critical ill patients apart from cardiac surgery? Is there a common pattern? What are the points where you would say these are clinical aspects which are more important in cardiac surgery versus in sepsis or trauma? What's your point on this?
You mean when to start CRRT?
When to start and when to stop specifically? Yeah, let's focus on the point.
I would say the difference is always the underlying condition and disease, because the most of the patients in the cardiac surgical field do not have an absolute indication for renal replacement therapy, such as hyperkalemia or intoxication. The most of our patients have, in the end, a fluid overload, which leads to an, I would say, venous congestion of the kidney, and therefore to refractory hypoxemia. And we need to introduce renal replacement therapy to get the fluid overload targets reached. So this is, I would say, difficult to different to other patients just when we think about sepsis. But what we also have is, of course, we have the most severe cases. Just think of type A dissection or something like that. Then we have also crushed kidneys with high myoglobin levels and so on. And we also have septic patients which need a continuous renal replacement therapy in the end. So there is no difference. But in first line, when I think of acute kidney injury after surgery, then I would say it's more or less the fluid overload. And this leads to that we have more or less time to decide to start.
Okay. So I just now I look into the FNAs. So there's one question related to the flowchart you showed. So maybe you can elaborate a bit more. So the current decision making around when to stop for the first time, maybe after the first cycle of renal replacement therapy. What are the criteria you really look? Which ones in the lab chart, which ones on the bedside? What do you look and what do you discuss with the colleagues before you really make the decision, yes or no, we stop now after 3 days when the cycle has not been broken earlier?
Yeah, I would say within the first 3 days, it's not that often. It's sometimes more than 3 days. The main outcome or the main thing we look at is hemodynamic stability, which has to be reached, which is more or less the key in our patients, because most of the patients have a right heart failure, which is underlying disease leading to a kidney disease, and also we have left heart failure patients who had too less cardiac output, to break it down to the certain point. And when we have our hemodynamic and respiratory targets reached, then we look if there is urinary output in our patients. But sometimes, as I tried to say, we have patients who do not have urinary output at all because they were on a negative balance for 6, 7, 8 days, because we have and we had fluid overload of more than 10 to 15 liters in those patients, and we had to put them on negative balance. So the kidney will not produce urine when you have a certain amount of negative balance over several days. And sometimes we try, when we think that there is hemodynamic and respiratory stability, and we think the kidney has recovered, to stop the CRT when the end of the filter lifespan has been reached. And then we look for 1 or 2 days if urine is coming out and no absolute indication for re-CRT is given. And in some cases, this works very well, and we can go on without renal replacement therapy. I hope this answer helps.
For sure. Yeah, the data you showed is what's intriguing to me is considering you're coming from a high volume center, and in this decision-making process, a lot of smart people are involved. And nevertheless, looking in your data, although preliminary and in a small cohort, it's obvious that the decision-making has some gaps. So we have a certain number of patients, which is a bit below 50%, which require it again. So the assessment of recovery is obviously a gap, despite all education and efforts we currently do. And you are doing better than the literature, obviously. Then the literature goes up to 60-70% sometimes of a return to dialysis. But it's very intriguing, and obviously a gap which could be closed by using biomarkers. You showed the approach. I would be interesting to hear your opinion as a provider. When we would now take a biomarker into the play of decision making, what is your opinion? Would you benefit from a biomarker who gives you an indication of do not stop it? Or would you want a biomarker who gives you an indication of yeah, you can stop. The patient is safe to stop, go forward. So what is your tendency when it comes to such an aspect?
Yeah, thank you for that question. As you mentioned, what we also found in this study and what was also interesting to us is that there is, as I told you, a wide variety of different approaches, not only institutional, but also individual. Although we are used to those patients, we also found that we have, I would say, not that standardized CRT weaning protocol. Yeah. So a standardized CRT weaning protocol, as I showed you, with the addition of a biomarker, can help us in stopping CRT. I think this is the question is not to start the CRT. This is, I would say, clinically easy. Yeah, but we are really looking into a black box. When can we stop the CRT? And when we can stop it earlier, then we can think about earlier mobilization or switching patients to an intermittent hemodialysis mode, which also will improve the outcome because we adding additional ICU days to our patients who cannot be mobilized, who have a risk for catheter infections and so on.
Thanks a lot, Professor Bernardi, for this presentation. It was a great talk. It was great to have you here. And to all participants, again, reminder, this is recorded. Share, if you like it, share it with your colleagues to have a look. And I'm sure we will see more things coming up from Vienna around this topic soon. So watch out. With this, I wish you a nice afternoon. Have a good rest of the week and see you soon.